Well, don't blame the GPs, right? I mean, we do a lot of things, and I think the problem is with 6-minute or 6 to 10-minute time slots per patient, it's automatic. We forget things, yeah? And some things we don't even know because we can't keep up, right? I mean, this is a statistic of new PubMed listed publications per month during the past 30 years. And as you see, in 1979, it was 25,000, which is a lot, isn't it? But now we're up to 80,000 new medical publications every month. And of course, a lot of that stuff is published only because the people need to publish, because you need impact and whatever, you know, for your career and so forth. And a lot of it is crap. You can just forget it. But there are probably some of the papers in there that are important. But how do you pick them out? I mean, this is impossible for a GP. So do you want the pharmaceutical companies to pick out what's important? That's what usually happens with pharmaceutical-sponsored education. No, we don't want that. So there must be other ways. Anyhow, Kroll did a study in 2003, and at that time, and now we have more publications, a doctor would have to read about 20 articles to keep up with changing and increasing medical knowledge per day. Did you read your 20 papers yesterday? Today it's pretty early, so how about yesterday? How do we go about to increase guideline adherence? We heard about one possibility yesterday, pay for performance. And Martin showed us that the quality regarding guideline adherent care was increasing even before. So it's just one little stone in the big picture. Clinical decision support is another option, but again, I think the most important would be we should have actually more time for the patient and should have less patients. And I don't think it's a wise idea to increase the number of doctors because the system will not be able to afford that. But a lot of the things, and this is, Martin showed yesterday, this is what happened in the UK with P4P, that work that does not necessarily need to be done by doctors is delegated to nurse practitioners, etc., which are hired by the practices. Let's go to the other side. Medication error. This is the harm that is done to patients because they are getting drugs or the wrong drugs. Let's take a look at Austria. The Austrian Health Report 2010 just came out a couple of months ago, and I couldn't believe it when I read that. Austrians consume 227 million packages of medication per year. That's 28 packages per person. And I think they don't consume it, but they get it from the pharmacy because these data come from the pharmacy market. So we should rather say 227 million packages are sold by the pharmacists to the population every year. Now, about 1/3 of these 227 million come out of primary care, which is about roughly 70 million prescriptions or prescribed drugs that come from primary care physicians. There's about 1/3 over the counter, and there's 1/3 in the hospital, of course, and there's a small percentage prescribed by specialists that are in the ambulatory sector. Over-the-counter also poses a threat to patient safety. As you all know, there are a lot of herbal medicines that do have interactions with other drugs and may influence pharmacokinetics and thus influence the rate of side effects. Now, we just did, within the Linnaeus project, we did a systematic review on the prevalence rates of adverse drug events, and we came up with a median of about 12.8% in the ambulatory sector. Of course, not all of these adverse events are serious adverse events, but all of these adverse events were serious enough to be reported. And I think the real figure of side effects that aren't even reported and are never detected is probably a lot higher. Still, 12.8%, that's more than every 10th patient that comes in with a side effect after we give him a prescription. Or he doesn't come in anymore, but he doesn't take the medication anymore, and he doesn't even tell us. And another result of this systematic review is that about 16% of these adverse drug events are preventable, are due to error. Now, if we go a little bit farther and we take a look at hospital admissions. In Austria, we have about 2.2 million hospital admissions per year, and about 0.9 million are unplanned. The rest are planned checkups, elective surgery, etc. And of the 0.9 million unplanned, we don't have general data from Austria. We have a small study on elderly patients that I will show you in a minute, but we don't have general data. But we do have a pretty good study that shows the general proportion of unplanned hospital admissions due to adverse drug events. And this is a study from the Netherlands, and they came up with a figure of about 5.6%. Now, if we apply this to the Austrian numbers, we come up with about 50,000, between 50 and 60,000 unplanned hospital admissions per year due to adverse drug events. And that this is another result of the Dutch study. About half of these admissions would have been avoidable, preventable, and are thus due to errors, medication errors. If you take a look at the costs, in Austria, 1 day in the hospital costs about 450 euros. I'm sure there are countries where it's a lot more. And the average duration of stay in the hospital in Austria is 9 days. So that comes up with a nice little sum of 10 million euros per year for hospital costs because of adverse drug events. This is the study I just promised. That was done in Austria, in the Austrian University Hospital, Salzburg University Hospital. And these colleagues of mine from the Department of Cardiology that I'm working closely together with, they found that 35% of the patients coming in through the emergency department had at least one unnecessary medication. And they had an average of 7.5 drugs per patient. These were patients over 70 years old, so an elderly population, and about 30% of these patients had inappropriate medication for the elderly according to the Beers criteria. Almost 10% had a double medication. They had 2 beta blockers, 2 ACE inhibitors. about 20% had the wrong doses. More than 60% had at least one possibly dangerous interaction in their combination of drugs. About 20%, almost 20%, were admitted to the hospital because of adverse drug events, and I said it wrong. It had adverse drug events that were detected when they were admitted, and about half of these, in half of these cases, the hospital admission was directly due to the adverse drug event. So that's a lot higher than the Dutch figure, but these are not general population, but older elderly people with polypharmacy, right? Interestingly enough, my colleagues also took a look at with how many medication did the patients leave the hospital. You can guess? 8.5 drugs. This is not a picture from the 1960s. It was taken recently at the same hospital, I must say. And I wonder whether really anybody knows which medication this patient is taking, and I wonder what the list looks like in the dismissal letter for the GP that I have to go through then and discuss with the patient what he really needs, because it's impossible that he can take it all. And you all know these cases. What are the adverse drug events due to? Which types of drugs are? It depends a little bit on the age of the patient. In children, it's mostly antibiotics, analgesics, respiratory drugs for asthma, and CNS drugs for epilepsy. In adults, there's a increasing number of cardiovascular drugs, in the elderly even more, and in the elderly we have also anti-cancer drugs, and CNS drugs are everywhere, which is, I think, a big problem.